Hello, everybody. I'm John Rossi, and I have the honor and great pleasure of introducing our speaker this afternoon, my good friend Mark Brown. Mark hails from the great state of Oregon, where, if I recall correctly, they welcome people to visit, but not to stay. And that's still true? That's still true, yeah. But still, it's a great state, yeah. One of the most enlightened and progressive. And he went to medical school in Oregon, right, in Portland. And then he did have was it a year of surgery? Emergency medicine, and then saw the light and transferred to psychiatry. And it's been a great pleasure to have him in our department. Mark has quite a list of achievements. He has been involved in a variety of research activities going back to earlier years, even before medical school, right? Yeah. And has a number of publications, of which he is the first author. I won't read all of them. He has received the Young Investigator Award, honorable mention. He's an honorary member of Alpha Omega, has received the Frederick Whelan Award from the psychology department in Portland, right? In college, right? Before medical school. And in recent years, in addition to his excellent work in the department and his leadership as a chief resident, he has had a sustained interest in the area of sleep. He's worked with Dr. Kwan, who has moved from this School of Medicine to, is it Harvard? But he continues to have a presence here and to sustain some activity, and Mark has worked with him. And then Mark spent a month with Dr. Kwan and the team at Harvard back in October, and has an appointment at Stanford as a fellow. He will be there for a month and come back briefly in June, and then he'll spend the next academic year doing work with Dement and others to further his expertise in that area. And we were talking about the richness of the sleep area and how it really affects practically every aspect of life, from health and development to pedagogy to normal behavior to implications with the law to safety to nutrition to weight to a variety of health issues to the integrity of our brain and on and on. And we will witness some of these rich associations as he talks about primary sleep disorders and their implications in psychiatry. He'd like to start with the emphasis on the sleep and then point the discussion towards psychiatry, since we're all fairly familiar with the sleep problems of our psychiatric patients. It has been my pleasure to work this year with Mark, and we have met weekly and gone over some material. And I've always picked his brain on a variety of issues, including sleep, have learned a lot from him. And this afternoon, I look forward to learning more and Mark staying awake.
Okay, well, thank you very much, Dr. Rossi. It's been an honor to meet with you and know you during residency here. So today, as Dr. Rossi mentioned, I'm going to talk about sleep medicine and its relationship to psychiatry. As you can imagine, it's a pretty complex association as far as the direction in regards to etiology or symptoms or both. As well as the sleep field. It's pretty big. If we're going to give a talk on awake medicine and psychiatry, it'd be a pretty long talk. So I'll try to focus it down a little bit and give pertinent examples that we might find useful for psychiatrists. I'd like to start by just looking at how our thinking about sleep has changed. This was a quote from Robert Macnish in a book, The Philosophy of Sleep, in 1834. And they typically think of sleep as a time where nothing much was going on and everything happened when we were awake. Sleep is the intermediate state between wakefulness and death. Wakefulness being regarded as the active state of all the animal and intellectual functions, and death is that of their total suspension. This is a painting from 1874 by John Waterhouse that shows Sleep and his brother Death. Sleep is the gentleman who's illuminated there in the light, and Death is his brother next to him. Our thinking now is quite different. We realize through a variety of studies that sleep, as said by Hobson, is a very dynamic behavior. It's not simply the absence of awake, but it's the special activity of the brain controlled by elaborate and precise mechanisms. So just to give you a quick overview, give a little brief introduction generally about sleep. And then I thought it'd be interesting to talk a little bit how we measure sleep. That's something that we don't get a lot of. And then talk about the primary sleep disorders in the relation to psychiatric morbidity from them, as opposed to the relationship of the primary psychiatric disorder and then its effect on sleep. And briefly touch on a few interesting pharmacological issues. So sleep problems are very common. Sorry, I have to kind of lean over here. Sleep disorders are very common. It's estimated about 10% of the population has a sleep disorder that's clinically meaningful. There have been numerous studies looking at the psychiatric as well as physical morbidity and mortality from sleep. Today we're going to focus most on the psychiatric. It's quite under-recognized, although this is getting better. I think just a few years ago, when I went to medical school in 2001, we had about 1 day or about a half a day on sleep. So, but that's getting better. More and more people I talk to are interested in it and know quite a lot about it. And we kind of touched on the issue between sleep psychiatry and the issues there. So measurement of sleep. This is the picture there is of a little guy who's hooked up for polysomnogram. Amazingly, little kids can tolerate this fairly well. You can see that he has, I'll try to see if I can use the pointer here. He's got leads hooked up for his EEG as well as his EOG, looking at eye movements. He's got a pressure transducer right here that measures his breathing, chin movements here. He's got some bands around his chest and abdomen that measure respiratory effort, pulse ox, things like that. So, but we start off with the history and physical, like any other specialty in medicine. History is also a very important time to screen for psychiatric disorders, as we'll get to. Sleep diaries are a good tool that we use, especially to when we're looking for insomnia or for circadian rhythm disorders. Actigraphy is, as you may know, using a watch-like device to measure light and movement and can give you more objective data about someone's sleep habits. PSG is what this little guy is hooked up to. It's the overnight sleep study that you hear about. I have an example of that on the next page. The MSLT is something that we hear less about. It's called the multiple sleep latency test, and that's something where you give the patient 5 naps throughout the course of the day after an overnight sleep study. You look at how long it takes them to fall asleep, and it's a way of measuring objectively how sleepy they are during the daytime. And that's used to diagnose narcolepsy, things like that. Then there's the maintenance of wakefulness test, which that measures your ability to stay awake. So they put you in a dark room, lecture hall, someone droning on, and see if you can stay awake or not. And that's typically what's used for people that need to stay awake in their jobs, like pilots or bus drivers or whatnot, as opposed to us who don't need to necessarily stay awake all the time. This is an example of a PSG. It shows, here's the EEG portion. Here's the eye movement portion. Down here we have the respiratory effort, abdominal effort, EKG, oxygen saturation. From that you can tell their sleep staging, and if they're having either abnormal movements of sleep, breathing problems during sleep, etc. But we typically, how do we measure sleep in psychiatry? Well, we get a report in the morning about how many hours the patient slept overnight. And interestingly, there's a study done looking at this. So how accurate is this? This was done in 1970, but I thought it was interesting. So they looked at 20 patients on an inpatient unit, and they compared the nursing observations with objective PSG. And interestingly, they found that there was good reliability for schizophrenia and mania patients, but very poor reliability for depressed patients. And they postulated this might be due to the fact that people who have schizophrenia tend to have extended sleep onset latency problems, so it takes them a while to fall asleep, but they have less interrupted sleep than people who are depressed or have early morning awakening issues. It was accurate in less than 25% of patients. So, it's something that, even if you hear the patient slept 8 hours at night, if they're depressed, you might want to, check in with them and see how they're really doing. And you might find, oh, he says you slept 8 hours, and then sure enough, no, I just slept 1, or it was horrible. So, so here's a list of some of the primary sleep disorders. It's not exhaustive, but these are the ones on the right, typically ones that we deal with and know a little bit more about in psychiatry. The ones on the left, a little bit less about, and grouped into sleep fragmenting disorders such as sleep disordered breathing, RLS, periodic limb movement disorder, or REM, sleep behavior disorder, and then disorders of hypersomnolence, narcolepsy, and idiopathic hypersomnia. I'm going to focus mostly today on the insufficient sleep, sleep disordered breathing, and RLS, and then a little bit on narcolepsy. So this, let's start with insufficient sleep. That may look familiar to you. About 20% of 1.1 million people surveyed noted that they sleep less than 6.5 hours per night. Our basal sleep need that's estimated in epidemiological studies is around 8 hours. So we're getting significantly less than that. There's, as we mentioned, medical consequences of getting less sleep. You can have increased coronary events. Looking at the Nurses' Health Study, they found that those with less than 7 hours of sleep had a 2 to 3-fold increase in cardiac events, and it changes evening cortisol, changes leptin and ghrelin that may increase propensity for appetite. It also decreases glucose tolerance. There's changes in natural killer cell activity, lymphokine activity, cytokines such as interleukin-6 and TNF-alpha. There's also been shown to be increased mortality in those who get less than 6.5 hours of sleep, but also in those who get more than 6.5 hours of sleep. So, looking now at neuropsychiatry effects, there's cognitive, psychomotor, and memory impairment in people who are sleep deprived. This was a study that was looking at sleep restriction of 3, 5, and 7 hours in patients over 1 week's time. And they had impairment in psychomotor vigilance tasks. And interestingly, subjectively, people felt that they recovered after 1 night of sleep. However, objectively, they didn't recover even after 3 days of recovered sleep. They looked at also people's differences within sleep. So some people may say, oh, I only need 4 hours, I do fine. Some people, are like, I know I need 10 or more. So they looked at sleep deprivation or ideal sleep times in people, and then 8 weeks later looked at it again. And it's pretty stable within people. People tend to have the same amount of sleep need, but it's different between people. We don't really know if that's, in fact, that people have decreased needs and physiologically it doesn't make a difference, or did these people just have increased resilience to decreased sleep? Here's a picture of the upper airway. So sleep disordered breathing is a phenomenon where there's a breathing disruption due to obstruction of the airway or a decreased breathing drive, which is referred to as central sleep apnea. We call it sleep-disordered breathing now because there's essentially a continuum of breathing problems, everything from normal to simple snoring to what we call RERAs, or respiratory event-related arousals, where everything will look normal on someone's EEG, but if you put down a esophageal manometry probe, which if you thought it was hard to sleep with all that stuff on your head, you could imagine having an esophageal probe down your esophagus while you sleep, but they do it. And you can see increasing crescendo changes in intrathoracic pressure and then an arousal on the EEG, so even when the breathing looks normal. And then it goes on to increasing severity of from hypopnea, which is just a decrease in breathing, to full-blown apnea. So the main problems with sleep apnea are that you have deoxygenation or desaturation during sleep, which can cause some of the morbidity, mortality that we talked about, but also the sleep fragmentation. This is looking at sleep apnea, and here you can see the values or stratification of that. It's pretty common. 4% of men, 2% of women have significant sleep apnea, and that's from a large study that is probably the most accurate, but there have been a lot of other studies that actually show increased estimation of sleep apnea, but that's also, this is just sleep apnea, not looking at issues where you can't see it on the PSG. So important things to look at when you have someone who comes into your office and you think this may be an issue would be looking at snoring. Does their bed partner notice them stop breathing at night? Do they have choking arousals where they kind of cough awake? I could do a bunch of impersonations here, but then it's really important to get the spouse report from it, because people often tell you, no, I don't snore, no, and their spouse will tell you something else. We're notoriously bad at gauging our own sleep, and oh, I wasn't asleep or whatever, and then you can look on PSG, in fact, they're in stage 1 sleep. Signs to look at, some of the best predictors of sleep apnea are BMI, neck circumference, and hypertension. People with sleep apnea don't have to be the kind of Pickwickian type of presentation that we thought of in the past. People who are thinner can have sleep apnea, children can have sleep apnea. So it's worth checking these symptoms. So there's long been an association between sleep disordered breathing and depression. And there's been multiple studies looking at this. Gimeno, who's a psychiatrist down at Stanford, in his original description of sleep apnea in 1977, noted that 25% of his 25 male patients with sleep apnea had significant depression. Reynolds noted that 40% of 25 male OSA patients met research criteria for depression and were at higher risk as their sleepiness increased. Millman noted that 45% of 55 OSA patients had depressive symptoms on the Zung scale, with a higher rating correlated with higher AHI, which is actually it makes sense, but as I was mentioning, because there's a difference between our ability to be resilient against sleep loss, you can sometimes see patients who have really bad sleep disordered breathing but aren't that sleepy during the day, and vice versa. Someone could have mild sleep apnea and be really sleepy. So that kind of throws another wrinkle into the mix. Musko noted 26% of his sleep apnea patients felt depressed, but 58% fulfilled DSM-3 criteria for depression. Akins noted that there's increased depression scores on the MMPI in 32% of their OSA patients, and there's twice as many with OSA and depression than age and sex matched primary snorers. This was a large review study looking at sleep disorder breathing and depression. The sleep eval was a survey of almost 20,000 adults. 857 of them had OSA, and the prevalence of depression in the OSA group is around 17%, and the rest of the sample 4.3%. A large VA study, they found almost 120,000 of them had OSA, 21% with depression, 9% rates of depression in non-apneic patients. There's part of the issues with these are that they're cross-sectional studies, so you can't show causation, but there does appear to be a significant association between the two. Again, there's the study by Pepper was a longitudinal study trying to address this issue of the cross-sectional nature, looked at them within 4-year intervals. And they did find that increasing apnea severity was associated with a 1.8 odds ratio of developing depression. This was a recent review article from 95 to 2006. That pretty rigorous exclusion criteria with a total of 55 articles. The mean age around 54, mostly male. They're pretty severe sleep apnea with the AHI, which is the amount of events they're having per hour, was 48, so that's severe. And part of the issue is they found in a lot of these studies that, there's a million different scales that people use to assess depression or mood, and so it's somewhat difficult to compare the studies. But they found pretty wide range, 7 to 63% pre-treatment, and anxiety disorders 11 to 70%, and about half of the patients who were treated with CPAP got better in regards to their depression or anxiety disorders. Only one of these studies was placebo-controlled, however. Okay, so this is a sleep heart health study, which was one of the studies I worked on with Dr. Kwan while he was here. It's a huge cohort study that takes cohorts from Framingham, other cardiovascular cohorts, and essentially pooled all their data. So they were able to get all this data from these different cohorts and then did sleep studies on them 5 years apart. So they also looked at a lot of different variables here on something called the mental component summary scale. But they didn't really show a whole lot of changes. Part of that could be because the change in RDI, BMI, sleepiness was all very minimal. And so they didn't really show an association there. Looking at cognitive dysfunction in sleep and sleep disorder breathing, this was another review article, and they found impairment in around 60% in attention, executive functioning, memory, and about 80% in construction and motor functioning. When they treated these patients, they noted that there was more of a response in these areas of attention, global functioning, memory, as opposed to psychomotor, and they hypothesized that that's because the attention and functioning, memory have to do with the lack of sleep and sleep deprivation, as opposed to psychomotor, which may be more due to hypoxic events that are permanent and not improved then by CPAP. So we can, as I mentioned, you can get sleep disorder breathing in children as well. And this is something to consider in the differential diagnosis of kids with ADHD. They can look remarkably similar. Sleep disorder breathing, like a lot of things in kids, doesn't present the same way. So kids typically, only 30% or so diagnosed with sleep disorder breathing actually say that they're sleepy. They tend to get paradoxical effects. They'll get more hyper. They tend to behavioral problems in school and such. So this was an interesting study with Dr. Shervin up at Michigan. And what they did was they looked at children who were going in for adenotonsillectomy. And this was for any reason, though. It wasn't just for sleep disorder breathing. And then they looked at a surgical control group. And what they found was that in the group that had adenotonsillectomy, when they looked at them, they tended to have higher scores for hyperactivity and attention, lower scores on MSLT, and were diagnosed more frequently in an interview with a child psychiatrist with ADHD at baseline. And then when they had the adenotonsillectomy, they improved to the control rate after 1 year. When they did PSGs on these patients before and after, but the only thing that really correlated with the PSG was the child's sleepiness in those kids that were. So essentially, they showed improvement. They're thinking that PSG for kids is not very good. Children tend to have much fewer events. The events that they do have tend to be not associated with arousals or with desaturations. It tends to look as though they have increased CO2 and some decrease in oxygenation, but it looks different. So the PSG may not be able to predict that, but it's interesting that this group was rated higher and did so much better. So we may be missing kids essentially that have sleep apnea, but aren't diagnosed on PSG with it. So sleep disorder breathing summary, it's a complex relationship. There's a 20+ year history of studies looking at this. It's clearly comorbid. The main take-home points, I think, would be regarding treatment. So if you have someone who could have sleep disorder breathing and they're having a lack of response to treatment, that would be consideration to refer them for a sleep study. Also, if you're thinking about prescribing benzos to these patients, benzos are not that great in sleep apnea because they'll increase the duration of desaturation in those patients. And then the ADHD overlap that we talked about. So moving on to RLS, restless leg. You've probably seen a lot about this on TV and whatnot with the medications. These are the criteria for RLS. Unpleasant limb sensations. There's a variety of descriptors for these. Motor restlessness. It has to be precipitated by rest and relieved by activity, and worse in the evening and night. So if you just ask someone, do you get uncomfortable sensations in your legs? Most people will say yes. So you really kind of have to rigorously apply these, or people will get misdiagnosed. A good way to do it is to say, if I came over to your house at night and you said that you couldn't move your legs for 10 minutes, could you do that? And that's usually sorts it out fairly well. But looking at something like akathisia, which we'll tend to see, it's typically not painful. These aren't absolutes, but typically not painful. It's typically not brought on by rest, and typically not relieved by activity or worse at nighttime. PLMDs, when people have very specific movements of their legs at nighttime. It's much like a Babinski response. They have flexion of their toe, of their big toe, and then fanning of their little toes, and they bring their knees up. And it happens on a regular rhythmic schedule. So you can have primary RLS, but there's also a variety of things that contribute to RLS, such as association with iron deficiency, renal failure, pregnancy, meds, often ones that we prescribe, like TCAs, SSRIs, are dopamine blockers, and also other dopamine blockers used in medicine, and caffeine can aggravate it. PLMD can be due to any of those causes, as well as withdrawal of anticonvulsants, barbiturates, hypnotics, and is associated with other sleep problems. So looking at RLS and quality of life in people, the Sleep Heart Health Study looked at this as well. And the RLS was diagnosed by an eight-item questionnaire and correlated with PSG findings. So it's not ideal in the sense they didn't have a clinical interview. But they noted decrements in all the physical domains and decrements in psychiatric domains of mental health and vitality. And this was a dose-response relationship. So the worse the RLS and sleep, the worse these were. This was another large study that was just recently published in Sleep, looking at a large sample of Korean adults, about 6,500. This was diagnosed with a face-to-face interview. And these measurement scales this is essentially a DSM-4 structured interview And this is a questionnaire, and this is a mood rating scale. And they found what we would expect as far as about double the incident or double the prevalence in women, and that it increased with age. They looked at in a correlational way, not in a causation way, but that those who had RLS were more likely to be on psychotropics, about twice as likely to have anxiety or depression, and had worse scores in their mood. They noted almost a significant increase in lifetime prevalence of DSM-4 disorders, major depression being the most common. And it's when they were looking at this, they did control for psychiatric medications when they were looking at the incidence of DSM disorders. So it wasn't something that was confounded by that. It was likely due to the RLS or sleep deprivation. This was a large review study by Winkleman, who was one of the guys out in Boston who does a lot of work in RLS and PLMD, and found again that depression was more common in RLS. It was exacerbated in those who were on SSRIs or SNRIs. But it was interesting, they're looking at, and it actually improved or was similar to control for bupropion or trazodone. So they had, even though there's no evidence-based recommendations right now for this, but important treatment recommendations for this. When they assess patients, they look at, as far as the criteria that overlap with depression and RLS, like psychomotor, agitation, concentration problems, sleep problems. They look for the other depressive symptoms in their depressed patients, so suicidality, anhedonia, those kinds of things. And if their depression's really mild, they might treat the RLS first. To give someone a dopamine agonist for RLS, the depression's likely to get better, not worse. There's case reports that those agonists actually help depression, versus if you give someone an SSRI and their RLS won't get better. If anything, it'll get worse. You can obviously look at decreasing, changing their medication. You mentioned bupropion, dicipramine, or trazodone may be good agents, and looking at prescribing hypnotics for these patients. So here, moving on to narcolepsy, this is a study of these Dobermans at Stanford. So there's a canine model of narcolepsy that's a little bit easier to look at than the human model. You can see they just kind of passed out mid-play there. They found a deficiency in hypocretin 1 and 2, which are secreted by the hypothalamus, and these affect the sleep-wake cycle by affecting norepinephrine in the brainstem. So they have a mutation in the hypocretin 2 receptor, but it's, like I said, more complicated in people. Twins, for example, there's only about a 20 to 30% concordance rate between the two. Narcolepsy is a problem of REM. Typically onset is in childhood or the 20s. The criteria, the tetrad for narcolepsy is sleep attacks. People get really sleepy all of a sudden and need to nap. They have cataplexy. It's not really like in the movies, where people just drop down on the ground. There's a funny story where they're telling me about a patient who had narcolepsy. She was a plumber, and she would be carrying her tools, and all the guys would try to make her laugh, because then she would just get weak and dump her tools all over the ground. So that's typically what people report when they laugh or have an emotional experience. They'll just get really weak and need to sit down. Hypnagogic hallucinations, so having hallucinations upon falling asleep, which can be quite severe, as we'll get into a little bit. And then sleep paralysis. Sleep paralysis is that feeling that you might have had where you feel like you're awake but you can't move your body, kind of like being under anesthesia and being awake. So it's pretty disconcerting. It can be normal in some people. It happens very rarely for some people, but people with narcolepsy have it all the time. You can also have secondary causes for this as well. As you can see there, it's diagnosed with a PSG and MSLT, and you want to see a sleep latency less than 5 minutes over the course of these naps, and then also that they need to have 2 or more episodes where they have REM during these naps. Normally you wouldn't have REM until around 90 minutes or so when you go to bed. You have slow wave sleep before that, but these people, they have REM immediately, so they have problems where they're awake, but their body's paralyzing itself. You can also look at HLA antigens, although typically that's not always done. So there was a study in pediatrics in 2006 looking at the psychosocial morbidity in children with narcolepsy. It was a cross-sectional questionnaire survey. They looked at behavior, mood, quality of life, and educational assessments. 42 of the subjects had narcolepsy, 18 had severe sleepiness without cataplexy. So there's a phenomenon where people will have sleep onset latency that's less than 5 minutes, but they won't have those REM intrusions, and so we don't know why they're objectively that sleepy and not having the REM problem. And it's usually called narcolepsy without cataplexy. They defined it as EDS without cataplexy here, and then a control group. And so they noted that there were significant differences for peer problems, conduct, emotional symptoms, and total problems for these children, but their prosocial and hyperactivity weren't different from controls. They were on the Child Depression Index more depressed in these sleepy groups than in the control group. The physical and global assessments weren't changed in these kids, but the mental health was. They definitely had greater educational difficulties. They don't really know why. They didn't have a lot of good follow-up on why this was. Was this because of the excess sleepiness, and they were having problems with the teachers, or were they getting made fun of, or lots of different reasons. They don't really know that yet, so that needs more study. Okay, so there's a few more interesting associations with psychiatry. So there's thought to be a association between narcolepsy and schizophrenia, and a subset essentially of narcolepsy that's psychotic. There's a case series of 5 patients. There's a few other case series that I didn't include in here. But these were all female patients. They had treatment refractory diagnosed schizophrenia, but they also had the full narcolepsy tetrad with cataplexy. And some of these hallucinations were, the voice of God being tied down, which was likely sleep paralysis. They also typically had all different sensory type of hallucinations, tactile, visual, things like that. So they did objective measures of their psychosis, negative symptoms, positive symptoms, and their overall psychosis, as you can see there, those studies. And it was pretty well designed. They did that beforehand, before they were on any treatment. And then they did not only PSG with MSLT on these patients, but they also did HLA typing on them. And everyone except for the first patient who, I guess these measures weren't out, it was too long ago, had statistically and clinically significant improvement of these scores. So we're talking scores in the hundreds going down to, say, 20. And that's after 1 week of stimulant use. Patient 1, for example, was put on methylphenidate. Patient 2 was put on pimozide. Let's see, patient 3, methylphenidate. Patient 4, methylphenidate and clomipramine. TCAs or SSRIs are often used for the cataplexy component. However, that patient had a manic episode and was switched to lithium and pemoline, which was effective. Patient 5 on dextroamphetamine and clomipramine had some anxiety with that and changed to pemoline with full recovery. So, you would expect that if you gave a psychotic individual a stimulant that they'd actually get worse. These patients had dramatic improvement. and there's all the patients had HLA positive for narcolepsy. It's sensitive, but not specific for the disease. It's thought that that this may be something to consider when you're seeing schizophrenic patients. Just to keep in mind, the patients that these tend to have, as I mentioned, hallucinations in several modalities, delusions that were correlated very strongly with their hallucinations, catatonic, not significantly thought disordered, and unresponsive or worse on antipsychotics, and have a positive family history for narcolepsy. They estimated around 7% of the patients in their neurology practice had these kind of presentations that were previously diagnosed as schizophrenic. And then just to finish up, looking at the pharmacology of sleep in psychiatry, I mean, this is kind of infinite, but I'm not going to go through a review, as everyone here is probably very knowledgeable on that. But interestingly, something I didn't know much about, and it's kind of interesting, gets a lot of press, is the complex sleep-related behaviors that are reported with medications like Ambien. These can be anything from sleep driving, cooking, eating, conversations. There's been reports of sleep sexual activity, and even you've probably heard of criminal behavior while people are asleep. And they don't recall these events. There was a large review done. They found 17 cases, most of them with Ambien or Zolpidem. It's not really sure if this is specific to Zolpidem, or is it because it's just prescribed so much more frequently? It's it's still a very rare event. The FDA has a similar number of cases that have been reported, but you can imagine if patients sleep driving, that's a pretty dangerous thing. So they have recommendations. One thing that typically doesn't get a lot of press, and it's worth stating, is that CBT for insomnia is highly effective. It's as effective as medications, and lasts longer. Typically, if you put someone on a hypnotic and then stop it, they'll relapse. However, CBTI has been shown to continue. That's kind of my plug for Dr. Boots and his lab here. But you can do things like decrease the agent, the dose, switch, obviously. Sometimes people will have other comorbid underlying sleep disorders, like sleep disordered breathing or RLS, that can predispose them to have parasomnias. Looking at other agents, we kind of talked about, patients with parasomnias are probably not a good idea to start them on. They should take them and immediately go to bed. Sometimes people will take them and stay up for a while. It can put them at increased risk, as well as alcohol. Hiding keys and garage openers, although people can do pretty complex things while they're asleep, so sometimes that's not always effective, but door alarms, things like that as well. Try to keep them safe. And then the last interaction was to have dopamine agonists, and the concern for risk of mania in patients, say, who have underlying bipolar disorder and also who have RLS. I mean, that was something that I was concerned about. If you have someone who's got bipolar, do I want to, and I've got them on a D2 antagonist, do I want to then put them on a dopamine agonist? What does that mean? There's a few studies looking at this, but not a lot of very good studies, surprisingly, actually. And a lot of them include Parkinson's disease with these, which kind of confounds it, because obviously there's issues within Parkinson's disease that predispose to psychosis. So this was a retrospective review of ropinirole for Parkinson's disease and RLS in an outpatient neurology clinic. 35 of these were RLS. We looked at those. 2 out of the 35 developed psychosis that required changing the therapy or doing something about it. They didn't find that it was predictive of having psychiatric disease before this. But as I mentioned, there are a few rigorous studies looking at this. So in summary, sleep disorders are quite common. They do have associated morbidity and mortality. It's important that we learn about them and assess them with our patients. They're underappreciated, but this is improving. The relationship between sleep and psych disorders appears bidirectional. And identification and treatment of primary sleep disorders may improve psychiatric comorbidity, but we need more outcome studies and treatment studies of this. I just put in a few, I'm not sure if this is in your handout or not, but put in a few resources here that are good that you can look at or direct your patients to. They have pretty good resources. I'll take some questions now if anyone has them. Yes, go ahead.
I'm interested to know what you have found about the inability of a patient to maintain awakeness during passive activities like reading, like watching television. And this is not, your typical falling asleep while you're watching television. I'm talking about trying to read, trying to study, and falling asleep, and what that has to, how you can associate that with a sleep disorder.
Yeah, I mean, that's interesting. I mean, they do have, I think, simulators for, say, driving and things like that, where you really want to assess someone trying to do that. I mean, the maintenance of wakefulness tests, as I understand, I mean, they're in a quiet room, but they are trying to stay awake. But I'm not really sure what else is out there right now that that assesses that. Yeah, I mean, there may be, but I'm not aware of anything that tests that specifically. But I'm sure there probably is.
You also noted that many of the studies are in the direction of sleep-ordered diagnosed people being tested for when depression or other psychiatric disorders show up. What about the reverse of patients who have depression, who have anxiety, being tested in the
Right. Right. Yeah. I specifically kind of gave this one direction because for time to kind of get through some things. But yeah, I mean, there's equal amount of literature looking at the other direction. I mean, there's even theories about depression causing sleep apnea because there's serotonin is involved in muscle tone in the upper airway, things like this. So it's a lot of really interesting research that looks at that. But just, it's such a broad topic that I thought I would just kind of...
Are the numbers as high? Are the percentages as high or higher from that direction?
Well, I think, if you look at, I mean, a lot of psychiatric disorders, insomnia, for example, is a significant component of those. I mean, this, in our criteria for depression and bipolar disorder. So I think that, yeah, I mean, there's definitely a strong effect in the other direction, but. Okay. Well, yes.
Schizophrenia, just to clarify. These are not patients really with schizophrenia. They look schizophrenic, but they're not schizophrenic. They're not schizophrenic.
Right. I mean, I think that as far as classifying them, yeah, I mean, you would then classify them as having narcolepsy, but they were previously diagnosed as schizophrenic.
Incorrectly so.
Right. And there's a little bit of debate about that, but I mean, and narcolepsy is such a rare disorder, and then combined with schizophrenia, which is 1% prevalence or so, that I mean, it's hard to get enough patients together. But yeah, it looks like that this is narcolepsy where patients are having hallucinations before they fall asleep and subsequently becoming psychotic because of that, really bad hallucinations, and then getting diagnosed as schizophrenic. So, yes.
Also, you mentioned about RLS, and there's an awful lot of evidence that that the taking of calcium is reducing the symptoms of RLS.
And iron also.
Yeah. Yeah, I mean, I'm not as familiar with the literature on calcium, but definitely, and I'm sure, I mean, it's related to there's a definite association with iron. And that likely influences the increased incidence in pregnancy or renal failure. You see people with RLS. And so assessing that's definitely important, and you want to treat that if it's there. It can definitely sometimes help patients. It's not as clear cut as we like it to be, but it's definitely something that you want to look at. So,
Thank you.
oh yeah, sure. They might attack you. Or no.
I just want to be clear on this point.
Okay.
You said that children who were having tonsillectomies or removal of adenoids before had a higher incidence,
Right.
or
So
after the surgery?
before, so they just took kids who were coming in for adenotonsillectomy, all comers for whatever reason, and looked at them in a control group, and the AT group had looked like essentially kind of looked like ADHD patients versus the control, and they took their tonsils out, and then they looked like control groups. But the PSG, the rub was the PSG didn't diagnose it. So they're kind of like, well, are we missing the sleep apnea then with these kids? Why didn't we diagnose the sleep apnea there? Because that's, the theory behind why they would have gotten better with tonsillectomy. But as I mentioned, the PSG is a lot different for kids with sleep apnea than it is for adults with sleep apnea.
Thank you.